Thank you so much for joining us today. I always look forward to our webinars because we consistently have such an incredible audience, and it's a privilege to connect with the professionals across the industry and share ideas, experiences, and learn from one another. Our goal today is to provide particular insights, real-world experiences, and actionable takeaways that you can apply in your own organization. Um, we appreciate you taking the time today. I know everyone is exceptionally busy, and we hope you leave today's session with valuable knowledge, fresh perspectives, and a few ideas you can put into your practice. Let me start with first introducing myself. I'm Anna Poliano, Product Operations Manager with Zentist. I've been with the company for about a year and a half. So still newer to the team, but prior to Zentist, I spent over 20 years working with different dental organizations, helping drive efficiency and growth. I also have industry experience working with Delta Dental. In the time I spent working with Delta, I learned a significant amount of information about payer contracts and claim processing guidelines. Joining me today, I would like to welcome Arna Myers. Arna is a technical product manager with Stedi. Stedi is the only API first clearinghouse, and Arna works with the cutting edge of dental claims, ERAs, and RCM automation. There are a few people in the industry that truly understand the system levels the way Arna does. I'm happy to have her join me today, and we are excited as we discuss claim denials, and what to do next. Arna, can you tell us a little bit more about yourself?
Yeah, hi, and thanks for having me. I really appreciate it. So, for those who have not met me before, my name is Arna Meyer. As Anna said, I'm at Stedi, which is a healthcare and dental clearinghouse. I've had close to 20 years of experience now in the dental industry. I started in the practice management space and then moved into operations and DSO operations. And now I lead industry efforts on advising the federal government on all things administrative transactions. So I'm the dental chair for WEDI, which is the work group for electronic data interchange. And we are the industry advisors to the Department of Health and Human Services for claims, remittance, eligibility transactions. And I represent the industry, the dental industry in particular, and our unique needs in those conversations. And so I'm really, really grateful that you invited me here to talk with you today. I think it's a wonderful topic and looking forward to getting into it.
Thank you. Thank you so much for giving us that background. So today, big topic of discussion, what happens after a dental claim gets denied? Today, we will focus on the part practices struggle with most. Knowing whether a denial is final, I think is a big one. Is it correctable or appealable? And what to do next. We will walk through a simple framework for triage, for really triaging denials and building a process that works when dealing with appeals or resubmissions. Let's see. Ooh, so sorry. I went too far ahead. My apologies. Let's look at our agenda first. In our discussion today, we look to cover a few key things. Administrative versus medical necessity denials, what separates them, and why it changes the way, why it changes what you do next, really, with a claim. The triage framework, is this denial final? Is it able to be resubmitted or appealed? And really, what's the difference between the two? We get this question a lot, I would say, in the industry. I think a big one is reading an 835, using remittance advice to guide your decision on what to do next. Building a strong appeal, of course, is a big part that we will cover, and then, of course, prevention. At the end, we will have some time and go over some of your questions. If you think of any questions as we do our discussion, please feel free to drop them into our chat box, and we will make sure we address those later in the call. Let's take a look. Now, let's get started. Arna, what are the biggest misconceptions dental practices have about denials? Really about denied claims, I should say.
The night claims, yeah. So I think when we get a claim in where there's been no payment, so let's say we send a claim out to the payer, it comes back and they just write everything off as a denial code.
Mm.
I think one of the biggest misconceptions I see is that people assume that that's a final answer. Um, so a, a sad reality is it actually is the start of the conversation, unfortunately. And just because a claim comes back with no payment applied to it doesn't necessarily mean that that's the final adjudicated state. The ERA or the EOB, I tend to work really in an ERA world, will give us the answer. Like sometimes it will have a zero payment or a denial
Mm.
with a code asking for more information. Or so in many cases, the ERAs will provide us with the information we need to determine the next step. And so this is where practices that understand the denial reasons and how to read these ERAs are actually going to be much more likely to recover payment. So, and we'll get into more of those details. But yeah, I think
Mhm.
the biggest misconception is that that first answer is the final answer, and that's almost always not the case.
Yeah, no, I agree. And I think from an operational standpoint, we work with a lot of different clients. I see practices make one or two mistakes. They either immediately write off the claim or the denied service, or they repeatedly resubmit the same claim over and over again, expecting a different result. And I think neither is effective in the industry. Every denial needs to be evaluated individually. The goal isn't to work harder, it's to work smarter by understanding, like you said, what the payer is actually asking for. We have to remember, not every denial is a lost claim. Every denial deserves an evaluation before deciding what the next action is. Now, this next question comes up often with, again, our current clients. Which denials are actually worth pursuing and which should we just let go?
So I've developed a bit of a framework, a cognitive framework to sort of think about this. There's really two types of claims and two types of denials. So the first bucket I think of is administrative denials.
Mm.
And this is usually missing information around the patient's or the provider's relationship with the insurance plan. So it might be missing subscriber ID. The birth date might be wrong.
Mm.
Um, there might be coordination of benefits. There might be missing information. But these are things that, um, if all of the information was correct, that claim would process through just fine. And so it's an administrative error. The other type of denial or claim I think about are the like the medical necessity claims and the medical necessity denials. And those are claims that we send out that normally need a little bit more evidence to um, prove. I don't
Mhm.
really like that word, but to prove that the treatment was actually necessary. And that it's those claims that go towards like a clinical review. And so that might be our perio claims. It might be some crown and bridges and needing those pre and post-op x-rays. And so the first thing is just really figuring out what type of denial we're working with. And that will then inform how we correct and resubmit those claims. But yeah, think of them in administrative or medical necessity. Um, and they're nearly always worth pursuing. There's going to be some stipulations around like frequency limitations that are just not collectible. But most of the time, a lot of this missing information can be fixed and resubmitted or attached and sent across to finalize that claim package to actually justify the release of payment from those payers.
Yeah, no, those are good points. When we do trainings and follow-ups with people, or we just look at our dashboard as a general, we have two buckets. We call it actionable and non-actionable.
Hmm.
The difference is actionable denials require follow-up, like you said, from
Yep.
the office that equal to additional benefits paid towards a claim. And spending an hour appealing a claim that has virtually no chances of being overturned may actually cost the office more money than it is to have no follow-up. So we really need to work with our team and understand what is denied, what requires follow-up, what's falling into this bucket, and what is worth following up with. Um, to really be efficient in the entire process and then have the opportunity to actually recover as well, right? We want to make sure
Right.
that we're providing the accurate information that can actually equal to additional benefits being paid. Now let's look at another question. Arna, how do you distinguish a claim that needs correction from one that actually requires a formal appeal?
Uh, it basically chalks down to, does anything on that claim need to change in order for the payment to be released? So if you need to change anything on the claim, then you would send a corrected claim. Um, if like that's if information's missing or incorrect, like that's a correction. If the payer received everything correctly and all the attachments, but it's a decision, like you disagree with the decision they made, that's an appeal. So I see a lot of the first where there's claims that just need to be massaged or they're just missing something. So it's just a lack of completeness. Those are handled differently as a resubmission. But if they've gotten down, they've gone to the clinical consultant said, look, this does not meet medical necessity. They've seen all the documentation, that would then trigger an appeals process, which is different. At that point, we're not sending claims anymore. We're in whatever appeals process the
Mhm.
payer has dictated you to use
Yeah.
in order to it's kind of like taking it to a judge. And
Right.
yeah,
I tell offices all the times to ask a simple question. Are you fixing the claim, like you said,
yeah,
or are we asking the payer to reconsider?
yeah,
If you're changing subscriber information, like you mentioned, CDT codes, attachments, or correcting demographics, that's a resubmission. If you're defending the clinical necessity of treatment, that's an appeal.
yeah,
Claims that need to be appealed state the reason of a denial. There's typically specific information that comes from the payer as to the reason for the denial, versus a resubmission asks for additional information. They tell you what they're looking for, like you mentioned, those periodic chartings, x-rays, etc. Corrections fix claims, appeals challenge the decision. So those, that's kind of the question and then the answer that you're looking for.
yeah.
Now, this leads us right into our next question. What documentation most often makes the difference between a successful and an unsuccessful appeal?
I mean, payers don't have, they only have what's right in front of them. So they only have whatever you furnish. And so what payers are really looking for are objective clinical evidence. So they are looking for notes and imaging, radiography, photos, perio charting that directly supports why the treatment was necessary. And this could be prior to treatment, like it's showing the patient history and it's showing yeah, you have to make the case for them because they don't have access to, they only have access to what you give them. They don't have access to the patient's medical or dental records.
Mhm.
They don't have access to that full comprehensive history. And sometimes, um, yeah, I get caught in the trap of forgetting that as well. We need to send that across. And so, yeah, it's just building the case for them so that it's clear cut why this patient, like why doctor determined this was medically and clinically necessary for this patient.
Mhm. Yeah, no, those are all good points. I remember from, industry background working with both in office and with Delta, one thing I always emphasize is that documentation should tell the patient's story. That could include, like you mentioned, x-rays, radiographs, periodic charting, intraoral photos, clinical notes, narrative explaining why treatment was necessary, and any previous treatment history that could um, emphasize and provide additional information as to why you did the treatment you did now.
Yeah.
The more clearly you connect the documentation to the treatment provided, the stronger your appeal becomes. It's also important to know your insurance payers' processing guidelines. I think this one everyone always forgets. If crowns are not covered because of attrition, you don't want to include that in your information and your documentation that you're providing. Insurance companies often change their guidelines. Again, that's something that we often forget. It's important to request this information frequently to truly understand what information that they need to process a claim. Oftentimes, the appeals are automated. A X-ray was not provided, it's denied. Charting wasn't there, it's denied. So you need to make sure that your information is really comprehensive. Strong documentation explains not only what was done, but why it was clinically necessary.
Yeah. And the progression is the other big
Mhm.
part of this as well. And so, the other thing to remember is like patients, like dental benefits are normally provided by employers, and those are more likely to be turned over. And so, even if we keep the same medical payer longitudinally for a patient over the course of a few years, dental payers turn over a little bit more. And so, behind the scenes, there's just a lack of visibility. And so, it's also showing we've tried this, and now we're at this stage, and just proving that we're starting at the lowest effective dose and moving our way up. But
Yeah, no,
yeah.
absolutely. Completely agree. Now, what are the most common mistakes practices make after receiving an ERA or really even an EOB?
hmm yeah, so like I said in the beginning, so many practices, they just look at whether the claim was paid or denied, and then they just enter that into their system, either typing it in manually or allow, like ERAs are designed to be ingested automatically.
Hmm.
Um, but they skip over the adjustment codes and remark codes. So there's two types of codes that come along in a claim, there's a claim package, and then there's line items, which is every unique procedure code. Um, will have claim adjustment codes, which will outline the financials of each of those. So what was written off, what was paid, what's the patient responsibility. And then they also come with remark codes, which those actually have, like, they're a wealth of information. They really
Mhm.
have the valuable info. Those are um, sort of dispositioning why. So they explain the decision behind the write-off. And so a RARC code, which is it's a remittance advice remark code. These are standardized across the industry. They actually come on both the ERA and the EOB. On the EOB, we're used to seeing like little numbers or letters next to lines, and then there's a little legend at the bottom of the paper. Those are your CARCs and RARCs. They're the exact same codes that come on a remittance advice. But what I notice is we just don't have very good systems as an industry on capturing those, interpreting them, and then knowing what to do next. And so actioning those.
Mhm.
But they actually tell us exactly what we need to do. And so they'll say, okay, um, we had a contractual obligation write-off. Easy, that's a write-off. And then we might have had a patient portion, so we know that. But if our contractual obligation is the full fee, we're like, okay, what's going on? And then we drop down to a remittance code and actually see why that was written off. Sometimes it's frequency limitations, which there's nothing we can do. Sometimes it's missing information. That's something we can absolutely do. Sometimes it's patient not found. And
Mhm.
and so it's just really understanding that the information is all there for us. We just need to know how to find it and how to use it and how to action it.
Yeah, no, those are great points. I'm showing you some examples of
Yeah.
some really good parts and remarks that kind of come together with different categories and how we show them in our system so that you can see a live view of how the two work hand in hand together. You know, you have your contractual obligation, but then you also have, you know, the reason why something was denied for frequency. It tells you how often the frequency is, etc. So there's a ton of information there. It's just like Arna said, really using that information and understanding it and knowing what to do with it next. I also see practices fail to create a follow-up plan. These denials get posted, but then no one owns the follow-up part of what to do next with the claim. Without accountability, claims just sit there for a long time, sometimes weeks, sometimes months, and then they're hitting filing deadlines. Um, you know, I think we really need to spend some time really reading the information, understanding those carks and remarks, making sure that we're following up, following the process of resubmitting, um, and then just making sure that our claims have a process to making sure that they're getting paid. So let's take a look at our next question here. How
Before
to,
we do, Anna, can we bring that slide back up just real quick?
yeah, yeah.
Because the other thing to think about, like we're talking about manual workflows a little bit here,
Mhm.
but once we sort of wrap our heads around this and we can do this manually, this
Mhm.
is one place that automation is really helpful because once we sort of understand the reason buckets, which I know Zentist, I've seen your platform and I know you I call it
Mhm.
dispositioning. Um, but once you sort of understand, like if we look at some of these rocks here, like the reason code um
like there's contractual
Yeah,
obligation, for example, on the exam. Yeah.
yeah.
And then it indicates that it's a frequency limitation.
Right. So these are designed to actually then informed automated workflows. And so as we get more comfortable and we start understanding this information, we can start designing work queues based on those codes because they're called structured data. So that whenever there's something that's codified like this, it means an algorithm, a computer can go
Mhm.
and pull anything with that code and put it in a list for review. And so as we look at these, again, the ERA data, it's designed to inform automated workflows down the line. And so the first step is always, as humans, we need to understand what it is we're working with. But as we start seeing these patterns and we start seeing the same things over and over again, we can move away from having to manually do this to working into an automated queue, which I'm sure we'll get into a little bit more. But I
Mhm.
just wanted to point that out as well because
Yeah.
that really is the whole point of wanting
Yeah,
to move
absolutely.
to this flow is so that we can cut out as much busy work as possible and move
Mhm.
to automation.
Yeah, absolutely. Now, how should teams organize their appeals and resubmissions so nothing falls through the cracks?
Um, you again, it comes back to really understanding what is paid as expected. So
Mhm.
if we send out claims and we get payments back, we want those posted and against the ledger. So the claims that are posted, we just want to get them into the system. And then we use our humans to start working the underpayments and zero payments. And so it's just capture first it's recognizing when there's an underpayment or a zero payment, and
Mhm.
then it's creating work queues that we can track and follow. And so that is, yeah. So how I think about this is I will use the reason codes to actually determine what the next step is, and then like so there's so one of the rocks that I love is like N940, which is missing or incomplete pre or post operative x-ray. That's cut and dry. That's telling me, okay, if you send me a pre or post operative x-ray, we'll process the claim and we'll probably pay it. And so it's just, again, having that translation layer because the codes just come through in letters and numbers, but then
Mhm.
having a translation layer from rock code to actual next steps and moving that through. The appeals is a little harder because that then gets out of your regular claims workflow. And so technically those are fully adjudicated and have to be posted as such. And so then it's determining how do we track those. And as an industry, we're still grappling with that. And
Yeah.
that's where vendor partners come into play because each insurance company has their own appeals process that isn't standardized across the industry. So resubmitting claims is really standard. Appealing claims, we've still got some work to do.
Yeah, I would agree. And I think many don't realize that when you are and actually truly appealing a claim and making sure that you can provide that medical documentation, there's often a completely different department that follows that. It's not just claim submission, it's not claim
Yeah,
processing. You're working with actual consultants on staff
yeah,
that are reviewing your claim, and those typically get sent to a completely different address. And making sure that you understand that process, where it goes, what is needed, that's very, very important.
yeah. But yeah, it should
What?
be the same workflow each time.
Mhm.
And
Oh,
so,
absolutely.
yeah, and so it yeah, it caught me off guard this question just a little bit because I'm like, yeah, you either close the claim, you work the claim,
Mhm.
and then you just need to know who's responsible. But it's just making sure it's visible is
Yeah.
basically what I'm trying to say.
Yeah, no, absolutely. I think one of the best things that practices can do is create a standardized denial workflow. Every
Hmm.
claim should have the date you received it, the denial reason, right? Things we talked about, understanding that denial reason,
Yeah.
who the individual in your organization that's actually working and doing that follow-up, what's the required documentation that needs to be provided, right? We talked about those guidelines that you need to ensure that your claims are comprehensive. Are you appealing? Are you resubmitting the claim? Making sure that there's a follow-up after that's done. One of the products that we offer is Caviar, and
Mhm.
I think we talk a lot in the industry about the importance of claim follow-up. Well, the system essentially helps you do exactly that.
Yeah.
It helps with that AR claim aging process and provides all of that information that we just spoke about, those cards, those remarks, those statuses of what needs to be done next. So basically creates that workflow for you. Everything by, aging, by, creating buckets. So, what's really past due over 90 days, over 120, what needs action. It does all of that separation, which is great.
Yeah.
Um,
And I mean, the aging is important too because of
mhm,
the other thing where I see a lot of people get caught up is the timely filing limits.
mhm.
And so those do reset as we keep working the claims, but we've got to stay on top of it because some payers only give you 90 days to finalize everything. Others give you a year. And so it's all, yeah, it's just understanding where you are in that process and really keeping receipts. Don't trust that. And I, in defense of the payers, um, even though I say don't trust that they'll keep a timestamp and of every interaction, it's so important to track these things so you've got the evidence and receipt of the work that you're doing. And this is where some practice management softwares have tried to sort of build this infrastructure out, but there's a lot of gaps. And so, yeah, I mean,
Yeah, I'm
this is
glad you
where
mentioned.
Cavi
Yeah.
AR is probably a really helpful product because I've seen it done in spreadsheets and we
Mhm.
need to get our spreadsheets.
Yeah. Yes. Spreadsheets are everyone's best friend, but enemy at the same time.
Oh
Um,
my gosh. Yeah, if I could take one product out. I love it, but I hate it, is Excel.
I'm glad you mentioned the filing deadlines. I think often
Hmm.
we don't realize that your network status often controls the guidelines. Some of the outer
Yeah.
network providers might have up to 2 years, but
Yep.
in-network has 6 months, a year if you're lucky. And some of these Medicaid, Medicare plans, you have 3 months. That's it. 90
Right.
days, no claim in, no patient portion. There's no collectible future there on that claim. So I have to be really careful with those submissions and those deadlines that kind of follow with some of those claims.
Yep.
Um, Now, how do you know when a denial points to a larger process problem rather than an isolated issue?
When you keep saying the same thing over and over again. So it I mean, denials are a gift in a sense if you use them as such to inform your upstream workflows. So, if you're seeing the same denial reason over and over and over again, chances are it can be fixed upstream.
Mhm.
Um, the one thing I really want to emphasize is that we expect denials. Like
Yeah.
I shout this from the rooftops. Insurance rules and their reimbursement rules should never dictate treatment. And
Mhm.
so we are obligated to still send claims for work that was done, even if we know it's not going to get paid. And so there is going to be some degree of denials. And so, like, for example, I'm a patient who gets a prophy every 3 months. My insurance pays every 6 months, and so I pay out of pocket. But my doctor still sends those claims because I have an in-network agreement, and they have an in-network agreement with the payer, and they're obligated to do so. But we all know my insurance isn't going to cover it. And so I think a big misconception is that we're trying to go to $0 denials, and that's not the case. But if you are seeing a lot of frequency limitation denials, then we know we're not tracking them upstream, and we can think about that because again, there's nothing wrong with frequency limitation denials
Mhm.
as long as it's an informed decision between doctor and patient about the costs. The same thing if we keep missing x-rays. Let's go upstream and figure out why x-rays aren't being attached to claims. And so it's just, you'll start to see these patterns over and over again. But the secret is to know, we want to get as much of the information away from the denial workflow and inform it upstream. And so, um, yeah, once we start seeing it, get curious about how we can solve this globally and move it up.
No, those are great points. This is where reporting becomes so valuable, right? We have a dashboard with a lot of data and a lot of information that lives within. Um, if one office, one provider, one payer continues generating the same denial, don't just fix the claim, right? Ask why is it happening? Maybe authorizations are not being obtained, eligibility isn't being verified, or documentation standards aren't considered. Denials often expose operational weaknesses, right? Areas that we know we can make improvements on. Recurring denials should trigger process improvements, not just corrections. We use these reports within our dashboard to work with offices that identify denial trends within their claims that are being generated by the different payers. So denial drill down is what we call this. So we can look at this on a payer level to see who is your highest denial provider, and then even open up the see more area and it shows you what is it that they're denying. And we could do that on a service code level also. If you're consistently having services being denied and they're major services, services that are high, production levels, you want to look and see that on your reports and then perhaps make some corrections on what could be done. If there are things like Arna mentioned, frequency issues, things you're expecting, max benefit, deductibles, we want to see all of that. But these are areas too, which sometimes is very helpful to kind of look at the broad overall picture and see really what's happening with all of your claims that come through the system. If a practice could improve only one part of the denial management process, Arno, where would you start? I know, big question.
Um, I mean, the single most helpful thing is probably like creating a decision tree. So, um, just learn how to categorize those denials
Mhm.
before anyone starts working on it. We do this, and so I want to give a lot of credit to staff in the practices. We do this without really capturing it and capturing our thought process because we've all, like, especially those of us that have processed paper EOBs,
Mhm.
um, we're used to figuring, like, we instinctively know when we enter that information whether we're going to split that claim and correct it and resubmit it. But what I would say is actually documenting that and creating the asset of a decision tree, so that every denial is understood before it's worked would be it. Yeah.
Yeah. No, that's kind of the answer. Like you said it perfectly. My answer is always triage. Not every denial belongs in the same work queue, right? Um, by first deciding whether the claim needs a correction or an appeal, you shouldn't simply close this. Practices immediately become more efficient and spending time in things that matter most. So classification, right? That's exactly what you said. And knowing what needs to be done versus things that don't. So having these different buckets that your claims fall into is really important. Um, your correct and resubmit and appeal, fall into these what we call the actionable denials, where um, patient's responsibility could be, your frequencies. Not much you could do with those. Your max benefit again, those are things that could be auto closed and nobody has to follow up with those. Or even contractual write-offs, right? We know we have to follow our fee schedules. So those are things that are, could be automated and could be taken out of those work queues versus things that really need follow-up and attention from our team. Um, Now, the role of automation, this is kind of a perfect segue into our next question. Like, where does the role play with kind of where we're headed to with the industry?
Yeah, so one gift that I've been in and around ERAs for a long time, and I remember processing my first dental ERA about 15 years ago, and now I work with hospitals and big medical systems on automating ERAs and their systems, and I've learned so much, and I'm really, really excited about how much work we can automate here, because
Mhm.
I've said throughout the presentation, ERAs are designed to be automated. The files, if you actually saw a raw ERA, are just they look like gibberish. The ERA that you presented was a human readable format. The
Mhm.
EOB is a physical printout of the same information that comes in ERA. What the ERA does that EOBs don't is ERAs are a federal standard. And so there are groups, and I'm part of these work efforts to actually make sure that the standards work for all industries. And
Mhm.
so where automation really comes into play is it like it can make practices faster, more informed in their decision making. And so my background is in open dental. So that's where I come from. And so open dental can take an ERA and automatically ingest it and post against the patient ledger. And so it can post the insurance payment, the write-off, and calculate the patient portion. And whilst that's great, where there's still an opportunity is around identifying the denial codes, categorizing those claims, and prioritizing work. Um, so where I like to say automation is going is around the next level. It's not just posting payments and setting and forgetting. It's what do we do next? So how do we identify underpaid claims, non-paid claims, underpaid line items within claims or non-paid line items within claims? And then how do we classify that work and either correct those claims and get them back out or get them into an appeals process? Um, but automation at its core is freeing up the humans that we have within our practices to not be doing the busy work, but to be moving more towards the exception handling. And
Yeah.
so yeah, I, I'll admit sometimes it's really nice to just sit there with an EOB and just do the manual key entry, although it can be really boring. Um, that's all fun and games until you get a $300,000 Medicaid payment and you're sitting there for 3 days trying to enter that manually. So there's the automatic ingestion, and then the second step is the automatic like filtering of what to do with those denials, like recognizing when there's something's underpaid, denied,
Yeah.
how to disposition it, how to work it. And then that's when like our revenue cycle management teams come in and actually focus on revenue recovery and
Revenue.
not the busy work of manual data entry.
Yeah, I'm glad you brought up those Medicare plans. One of the biggest things that I think the biggest value we bring to some of these large organizations that we work with is we see a high volume of, your bulk payments. They could be 30 or 40 patients, right? But they still take
Mm-hmm.
a long time to process. And then
Yep.
we look at that complete opposite end of the spectrum where there's, 300 patients on one AOB, there are thousands and thousands of dollars. And like you said, it takes you days sometimes to enter all of those claims when you're doing them individually and you're doing that manual workflow where automation just does the work for you. You're managing anything that just needs to be handled by a human, any of those follow-ups and exceptions. And I always remind practices that automation doesn't replace anyone, it empowers them, right? Instead of spending hours sorting through denials, staff can focus on resolving complex claims, building strong appeals and improving patient communication. Automation also provides valuable reporting that otherwise cannot be done kind of on, individually. It's impossible. Helping practices identify trends, measure denial rates, and continuously improve their processes ultimately, right? Some of the things we already discussed was that denial categorization, how impactful that could be. Routing claims to the correct work views. Some of those are huge when we're working in some of these big groups and big offices with multiple providers. Um, Now, as a takeaway, I would say, looking at this slide, 6 out of 10 offices are looking to move towards automation and not just with EOB processes. There's many different things that they're looking to improve and make those workloads better. But automation doesn't eliminate human expertise, right? You and I, Arna, we're never going away. We're going to be here forever. It allows teams to spend their expertise where it has the greatest impact. Now, let's take a look at some of these questions that we maybe had.
I saw a really good one come in that I would love to answer. I can
Uh,
read it.
yeah, please
Okay.
do.
So it says, um, and hi, this is me, Shob. I have a question. When sending claims to carriers and you receive a rejection or a denial, how do we determine which claim correction code we need to send? Like the 6, 7, or 8, the resubmission code with the original reference number. It's the DCN or ICN number that carriers assign to claims. Now, I can definitely answer this. I don't know if you want to get into it as well,
No,
but
no, go ahead.
okay. So yes. what, so this is part of the 837D. So I, again, we've got varying levels of understanding of who's on the call. So if we're sending those transactions electronically, we have a standard. It's X12, and we're currently using the 5010 version. And the claim transaction that we use in dentistry is predominantly 837D, which is a dental claim. And so one of those elements within the claim is the claim resubmission code. So the short answer is I can provide some documentation on where to find this, but six is a corrected claim. So that is you are replacing the claim on file. So if you are sending a claim with corrected information, you would use code six. Um, Seven is not really used today. It is a old code, which is the replacement or prior claim. Um, Eight equals void. And so that is you want to void or cancel, like you want to send in and void or cancel the previous code. What I usually see um, is when people don't understand whether to submit a brand new claim or to use a previous claim. So the question to answer is, does this payer already have the claim in their system? And am I replacing that claim with corrected information? And if the answer to that is yes, then we would use that number six and the original ICN DCN. Um, if the claim never got to adjudication, like it got rejected, because a rejection is different to a denial. So if you get a rejection before it gets to their adjudication system, then you would resubmit a new original claim with the status code of one, which is an original claim. Um, and the only other situation I really see is when we do a duplicate claim, and we may need to void one of those, and then we'd use an eight. But most of the time, it's going to be if you got a decision, use a six in the DCN or ICN. If you didn't get a decision, you just got a rejection, use the one. And yeah, I'll type an answer in with some resources there for you as well. Um,
No, that would be awesome. I think one of the things we hear a lot is there are so many CARC and records, and how do we work with those, right?
mhm.
And we'll of course provide some resources for you, but ultimately it's having the two work hand in hand together. Reading them to the fullest, getting down to the bottom line, and then the categorization. I think one of the things that we at Census have done really well is do exactly that. We provide that detail, we surface the information so that you're not having to read this very unfamiliar document that comes in a very digitized format. We've made it so that it was easy for the user to understand. Um, See, is there any other questions that are coming through?
I haven't seen anything yet. Let's have a look over on this
Oh,
side.
it's another question about how can AI help us find denied or denied claims and making our process automated. So part of Zentist and what we do within our dashboard is, when claim payments are received, there's the reconciliation piece where we're taking your bank data and matching that with EOB, ERA data to give you that information, match payments to remittance information. Part of that matching process is then, of course, parsing the information, providing your patient's detailed services rendered, and then giving you information within the claim that shows you your services paid versus services denied. And then this is the automation piece where when we show the line by line of submission, contracted, patient and insurance portion, and then we also surface that information for you in regards to the denials and then reason for those denials. Because those are in categories, those can then be automated into work queues. You can filter, you can create workflows, you can assign to user by making that process more automated. So you can take all your clean claims and take them out of the queue and only focus on the resubmissions, those actionable denials we talked about earlier in the call.
Yeah. Um, The beautiful thing about using ERAs is, again, it's all standardized. So every element in an ERA has a nationally agreed upon definition. So we're not using AI to interpret information, which is really nice. So that's what we call structured data. So everything is exactly what it says it is, and it's very cut and dry. Where AI or automation in general is really useful is then passing workflows, as Anna said. And so, yeah, we tend to use AI as this big blanket term. In this case, it's really automation. It's really just creating intelligent workflows on and like I keep saying the word dispositioning because that's really what it comes down to is it's like tagging these claims to know
Mhm.
what to do next. And so, where we still need people is to synthesize that information and move the workflows upstream. And so AI is really good at generating and creating work queues. And then the humans come in and our teammates, we're all in working those claims. What we haven't cracked, and I don't think artificial intelligence will, is informing upstream workflows on how to get better at collecting information at the time. So running those eligibility checks prior to the patient coming in or prior to sending a claim to make sure all the information is correct. We'll have rules engines around recognizing attachments, but um, it's yeah, understanding what automation is good at and where it fails, and then really understanding what humans are good at and putting us to our highest and best use.
Yeah, no, agreed. Now, I do want to share this slide. I know some of you are starting to jump off, so I want to make sure this is available. Um, if anyone is interested in further information, please feel free to use one of these QR codes um, to reach out to our teams to gather some additional information or schedule a demo with our team. But please continue to send those questions. I just wanted to make sure that this was available for you guys.
Yeah, and thank you everyone for taking some time out of your day to come in and learn about this. And if any of it is interesting to you or you'd like to learn more, both Anna and I are evangelists for this work, and so happy to connect and chat more.
Yeah, and I think we all have lived the era and the changes of the industry, which is, really understanding kind of how we evolved. And like Arna mentioned, the medical world is so much more evolved. And
Oh,
having, go ahead,
yeah.
Jessica.
Yeah.
You're
So,
reading
I
my
mean,
mind.
I know. So one thing that I'm working on really deeply right now is coordination of benefits. So secondary claims. So right now in dentistry, like when we send a secondary claim to a payer, we have to attach the primary EOB because technically, if we're using ERAs and we're using electronic claims, we don't need that entire workflow because all of that information from that primary claim will come through on that secondary claim and everything balances out. But it all pivots on us using the full scope of transactions. And so, what's really exciting to me is automating some of those workflows. Like my whole spiel, I'm trying to get away from using attachments to justify things as much as possible and getting them into the original claim. And so, because in medicine, we don't use nearly as much attachments. And so it sounds a bit counterintuitive, but the way to get there is actually by adopting ERAs and really getting that infrastructure into our claims management and our practice management systems.
Mhm.
Because if we get ERAs and getting them automatically posted into the system and everything balances out, and then we start using diagnosis codes like we do in medicine, it really reduces the amount of evidence we need to attach to a claim and out the door. And so it really excites me to start seeing some movement on the dental industry here because of the implications that that will have for our claims processing and our eligibility down the line as well.
Yeah, no, that's a good point. I think sometimes we don't realize how beneficial this could be, right? There's so many different practice management systems out there that are cloud-based and are moving to this type of workflow where they're working with your clearinghouses to ingest this data to be able to post and get the reconciliation piece moving, or they're working with vendors like Zentist to automate the adjustments and the payment posting and the denial
Yeah.
workflows and claim follow-up and all of the other things that that we can help provide to your organizations. And having this data come through on an ERA versus just an EOB, or using both. Sometimes both is important.
Mhm.
Um, is key to us moving forward and getting to the
Yeah.
same standard that medical has been for years, for a long time.
Right. Yeah. So my ideal end state, just so we're transparent, is we need healthcare transactions to be as fast and efficient as banking transactions. So we need the money to remit. Like, could you imagine if supermarkets still had to manually type in credit card numbers? Or remember, this is showing my age with the machines where we'd get the credit card, the carbon copy, and then we'd manually type that in. We're still at that level of sophistication in the dental industry, and we really need to get to a point where it's just a click of a button, claim goes out, payment comes in, and everything is settled. And this is the technology and the infrastructure that gets us to that point. We're at a really, and I also want to acknowledge we're at a really uncomfortable transition period. And the biggest word I hear when I talk to people about ERAs is trust. Like, how can we trust the information? And the answer is we just need to educate ourselves on what ERAs are and what they give us and what we can do with them, and then just learn to adapt to that workflow. Why paper EOBs have persisted for so long is remarks. It's those carks and rocks, and that's why we harped on them, is because they're obvious on paper, but in an automated workflow, unless you know what you're looking for, it's hard to understand that that's the information we need to go to the next step. And so, and the practice management softwares haven't always done a very good job of bringing both in the claim, like the CARC and the ROC.
Mm.
Um, and so understanding that ERAs give us everything we need. We just need to be able to see it. And
Mm.
again, that's why I'm loving what Zentist is doing here, because you are just making it transparent. You're creating the workflows. Um, but getting those in a digitized fashion, like, will get us to that endpoint. My ideal state is like we see a patient and 15 seconds later we have a decision. But
Mhm.
that will never happen whilst we have the expectation that people are doing remittance advice. Like, we really need to set the standard of moving towards automation to get to that point.
Yeah, no, I agree. Another question came in that
Oh,
says
sweet.
how claim scrubbers can help us to reduce denial rejections.
Yeah.
And how could we implement scrubbing in our system? I know there are many scrubbing services in the market, but how can I have my own scrubbing for my product, EMR?
Okay. Denials should be informing claim scrubbing. Absolutely. So, this is where, without sounding too salesy, I'm going to pitch. This is the role of a clearinghouse. So your clearinghouses should be learning from remittance and front loading. They're called edits. And there's actually a whole framework around this. They're called SNP edits, and there's 7 levels. The first 3 are just structural validation, and then we start getting and like that result in rejections, and then we get into SNP level 4 through 4, 5, 6 are payer specific rules, and then 7, yeah. And so there's a whole hierarchy of how this should work. And so the products that are selling claim scrubbing services in between a clearinghouse and a payer, or in between a provider and a clearinghouse, um, are interesting. It really should be a clearinghouse. Like, that's the whole point of a clearinghouse, is to normalize and validate that information, knowing what the payer rules are. Um, but how, because I help run the edits team here at Steady, we use a combination of 277 CAs, which are the claim acknowledgements, which will tell us if a claim, so there's 2 parts, like, to adjudication. So a claim comes in and it will hit a validation layer, and it may fail validation and gets bounced back. That should inform it, like, that's information. That's not a remittance. That is, we didn't even get the claim into the payer to get paid. And then if it gets through validation, then it goes to adjudication. It can still bounce at adjudication, and it come back. And if that's the case, we didn't get a remittance. And so that would inform, it's called a front end edit. But then
Mhm.
if we get it through the adjudication system and out the other end, that would result in a remittance advice. That should then, that decision is usually like, should inform a front end edit. It's those administrative denials. So
Mhm.
any of those administrative denials that make it all the way through adjudication and a denial could be front loaded as a rejection. The clinical, the medically necessary denials, there is no way to edit for those. You can infer some requirements around attachments, but for the most part, what we're trying to reduce are those administrative denials. And we want to catch those. And so your clearinghouse should be catching those and pushing those claims back to you before they even get out the door. But if they don't, yeah, it's trying to reduce as much of that administrative busy work as possible.
Yeah, I'm glad you brought that up. I think there's so many that don't realize or recognize that that's a functionality of what the clearinghouse actually does. It's supposed to give you those
Correct.
indicators, provide information on the guidelines, give you that feedback of what's necessary. You get those little paper clips, those little attachments that need to be completed, and in order for the claim to be finalized, and that all information is attached. And some of it actually allows you to, use those. Contract guidelines and processing guidelines I mentioned earlier with the different payers and even add your own rules, right? Like use your information coming from the clearinghouses, but also make sure that you're aware of what is needed to, what is the payer requesting and making sure that those,
Yeah.
especially on those higher value claims, they're so important to make sure that they go through and process.
Yeah. Would it be possible? May I share the screen for a second?
Yeah.
Okay. So bear with me a second. I'll just make sure I've got the right one. Okay. Can you see? Perfect. So this is from the study blog, but this is um, just a really helpful visual. So when we submit a claim, there's quite a few hops that happen between the claim actually leaving a practice management software or where an EMR and actually getting to an adjudicated state. And so the claim may come in and be received. We should get an acknowledgement. It could be rejected at this point and thrown back. That won't result in an ERA. That is a 277 CA rejection. We
Mhm.
may get through that initial validation level. And then, so this is the clearinghouse level, and then we send it to the payer. The payer can do the same thing. So they may receive it and then they may reject it. And again, still no adjudication. If they accept it into their adjudication system, this is where we get the ERA. And so we've still got two hops at the front end. This is where administrative denials should happen, but sometimes they make it, especially in dentistry, they make it all the way to this adjudication layer before they get a denial. So if you're talking about claim scrubbing, you want to learn here at the clearinghouse level, you want to learn here at the payer validation level, and then as a last resort, learning here at the denial level.
Yeah. No, thank you for sharing that. I think we're
Yeah,
running out of time here.
beautiful.
I think some of you had asked if this was recorded and if this would be shared. I believe the answer is yes to both of those questions. And I think we'll share some additional content with you as well that will help with the ERAs, really understanding the information and kind of what to do next. We thank you for spending the last hour with us, listening to us talk about what we know best.
Yeah, thank you so much. And yeah, please don't hesitate to reach out, contact us, and we're happy to talk about this anytime.
Yeah, absolutely.
Yeah, thanks, Anna. Thanks, Zentist. Appreciate
Yeah.
it.